Of the day.
Okay, can everybody hear me if I wear it like this? Okay, turnabout is fair play. I want to thank Mike Vaughn, where's Mike? And Millie Jones, and Michelle, and Carrie, and Ann, and Tracy, because without Mike, Millie, and the HCET staff, this wouldn't have been. So kudos and thank you for that. Okay, we're going to start. And for those of you who have stayed to the end of the day, thank you. As you know, I usually like to roam, but because we're taping this, I'm going to try and stay in one spot. So we'll see how it goes. I'm going to talk about contraceptive management, which we're going to talk really fast. And I want to try and get through my slides, and then we'll have time for some discussion and case scenarios or whatever you want to do. I do not have any disclosures, but I will be discussing some off-label use of contraceptives. The majority of the information is going to be evidence-based, but I am going to share with you some of my experience, which spans about 35 years in family planning. When I first started, all the birth control pills had 100 micrograms of estrogen in them. We had Dalcon Shield, Copper 7, Safety Coil, and Lippy Loops, and IUDs, and we didn't have any patch, and we didn't have any ring. Depo was in when I started, then it went out, and then it came back in. And in Wisconsin, when I started, only married women could get family planning services. Okay? So that's where I came from. And I'm not a day over 29. And if you believe that, I got some swampland I'd like to sell you, or some stocks that maybe ain't doing so good. We've heard lots and lots and lots of information today about LARC. And I am a big supporter of LARC. But I also know that about 60% of the patients that come in the door want a method other than a LARC. The majority of them come in the door wanting birth control pills. And I'm sure that that's probably your experience too. So we need to look at some of these other methods and how do we manage them. So we've got all these out there for us available: combined OCs, patch, ring, Depo, Nexplanon, Marina, Paragard, and the new Skyla, or Mini Marina, as you've sometimes seen that being written about. We've got oodles of resources. For those of you who are in, the program guideline family, you know about the US MEC that came out in originally, and then it got expanded to postpartum, and it got expanded to women with HIV, 20th edition contraceptive tech, and those of you that see me walking around, I have all my flags. Managing contraception we got today. Well, I've already had one, and so I have flags on that. And Dickey, which is managing oral contraceptives, and I have flags on that. So there's lots of stuff out there to help you manage and use for references. So let's look at each method. The US MEC, just as a matter of review, assigns a risk, you all know that, with 1, no risk, it's safe for use. 2, you can use, the advantages generally outweigh the theoretical or proven risks. Oop. Well, geez, Jan. 3, this is where I said 1 and 2 are no-brainers. 3 I ought to raise up and pay attention to. Because 3 says I probably shouldn't use it unless I've got some clinical judgment that the patient can safely use it, but a lot of times theory or proven risk may outweigh the advantages. And 4, I better not even think about using it because I can't justify it and I can't defend myself if something happens. So 1 and 2 are no-brainers. 3, you raise up and take attention, and 4, don't use it. That's an easy way to think about it. Now, how do you identify unacceptable health risks? For those of you as old as me, Unacceptable health risks were called absolute contraindications. That's how I started out umpteen years ago. Absolute contraindications, you don't use it. MEC came and went to unacceptable health risks. The most important thing, if you look at this slide, if you forget to take a history, you're in deep doo-doo. Because history is what's going to help you identify your unacceptable health risks. If you go into the MEC and you look at level 4s, all of them are history. You're not going to find them by laying on of the hands. You're going to find them by taking a good history. So spend the time to do it. So here's a couple examples of level 4. Age combined with smoking, migraine with aura, drives us all crazy. Current breast cancer, blood pressure 160 over 100 is a 4, postpartum less than 21 days. Those are 4s for all the methods, don't matter what. But there's some history information that's going to help you maybe decide what you're going to use for a method or what dosage of pills you're going to use. History of ovarian cysts might be one. We just heard chatting about bariatric surgery. That's going to be another, especially if they've got malabsorption issues. Weight, anticonvulsant meds, sedatives or hypnotics. These are all issues when it comes. Now, all of you in this room, if you're DPH, I don't have to spend time talking to you about emergency contraception and dual protection because you can say it in your sleep, okay? Because it is a priority practice. But, you know, you want to make sure you do it in advance of need, your male and female condoms. Dr. Hatcher talked about Paragard today as the best method of emergency contraception. We have all kinds of issues with that, accessibility issues, payment issues, the whole thing. We've got Plan B and Next Choice. Off-label use of that up to 120 hours, perfectly okay. Ella has been approved for 120 hours. Your birth control pills, there's a whole range of birth control pills that you can also take for emergency contraception. They're off-label use, and on your packet of handouts, you have a listing of them. So when you get back home and you get into that situation, you've got them available for you. Body mass index, BMI, there's recent documentation, probably about the last 3 years, about Plan B Next Choice effectiveness in BMIs and ELA. So that the data is saying BMIs 26 or greater, Plan B Next Choice is not effective, it's ineffective. And ELA is ineffective in a BMI of 35 or greater. Now, does that mean I wouldn't use it? No, because nothing is zero. Nothing is zero. But if you have options, you have both of them in your formulary, you have both of them in your clinic, you might want to use BMI as options for decision making. But remember, you have different rules regarding backup, and I've got a couple slides on that, versus Plan B versus ELA. So make sure of that. Quick Start, Dr. Hatcher talked about Quick Start today. It's an off-label use, but it is the preferred method for initiation of contraceptives, especially your pill, patch, ring, depot. And we've got to be careful about this when we're talking about IUCs and Nexplanon because of our payer issues and that 3-year limit on stuff. So we have to be careful with that. But Quick Start is your preferred method, but it's off-label. So what's Quick Start? It says you're going to start the method at the time the patient's in the room visiting you, and you're not going to wait till they have a period. You have to be reasonably certain she is not pregnant, and you can evaluate the need for EC, and if they need EC, then give it and start their method. Just as a quick review for you, and for those of you who aren't used to Quick Start, these are the questions you want to ask. Unprotected intercourse in the past 5 days, you give EC and start the pill, patch, or ring, or depot on the same day. Back up for 7 days, but if you're using ELA, your backup is for 14 days. The reference to that is in Contraceptive Tech, the big book, okay? And if they have no withdrawal bleed when they're due, then you want to make sure the patient gets a pregnancy test. So you're going to have to instruct them. If you're doing EC, depot, you're going to want to do a pregnancy test before that next depot shot. If you're doing EC, pills, patch, ring, it's hard to get them back in, do it at the time of the next supply pickup. If they come in complaining of symptoms, well then obviously, a pregnancy, obviously you do it when they present it, okay? You want to be reasonably certain they're not pregnant, so you ask, have you had a baby in the last 4 weeks? Do you have a baby that you had a baby 6 months ago and you're fully or nearly fully breastfeeding and you haven't had a period? Abstain from sex since the last period or delivery. Last period or delivery started within the past 7 days or 12 days for IUD. Miscarriage or abortion in the past 7 days or last for 12 for IUD. And they've been using a reliable method of birth control consistently or correctly. And that's a lot of times people come in and say, well, I've been using condoms, I've been using them every time. And they want to switch to pill, patch, ring, Depo, quick start them. Okay. If there's no to all the questions, you got to wait for a period. And if yes to any question, no signs of pregnancy, start them. Back them up for a week. Okay. Now here's a tip. You have to have Jan's tips. This is a Jan tip. Okay. When you're doing quick start for your pills, you better stop and look at how the pills are packaged. Because Loavril and Nordet are packaged for Sunday starts. Their generics, though, allow an any day start. So you got to look at your formulary, and you've got to look and see what you've got and how they're packaged. The day stickers are those little things that you can peel off and put over the top of the days of the week on the packages to start them, to alter that first day start. I want to do another little tip. And not to pick on ortho, but the regular ortho products, ortho-tricycline, ortho-cycline, they're in that round compact. And the first, well, cycline you don't have to worry about, but tricycline low you do. First white pills up here, it says Sunday. And you got this round little day sticker with all those knobs on it. Pain in the butt to get it to fit. The trick is, look at the day sticker, find a blue day of the week that you're having them start it, and put the blue day of the week up on the first white pill, and then all the little knobs will fit. That's a tip. It took me a while to learn that. So now, if you haven't done it. If you have never sat down and looked at a pack of pills like that and tried to put that day sticker on it, you ought to go home and do it. Okay? Because they didn't ask providers when they developed that. That's my editorial comment today. Okay. Patients wanting patch, ring, or shot, they've only got one product to pick from. We don't have umpteen rings and patches and all that stuff. We've got one patch right now, one ring right now, and one shot right now, although Depo can be sub-Q or IM. Is anybody using sub-Q Depo? Okay. Now, I'm going to just give you some quick things, and the important information on this is the compound. Because when we start talking management, we're going to be looking at the compounds. So the patch has got an active metabolite of norgestimate in it, and ethanol estradiol. Okay? So estrogen, ethanol estradiol, norgestimate, your progestin. Okay? This is how much the patient gets every day in the patch. It's absorbed through their skin. Okay? Ring, here we've got a metabolite of desogestrel, we got etanogestrel. This is how much the patient gets. This is how much it releases. Okay, so now we've got norgestimate and desogestrel, still only one estrogen. Okay, shot, now we got dopamine acetate. This is IM. It is available sub-Q. I didn't know if anybody was using it. It's pretty pricey. So I didn't think anybody was using it, but I wasn't sure. Okay, so we've got that. Now that's progestin only. Then we got Implanon/Nexplanon. I think Implanon is pretty much probably about all used up. I think you're only getting Nexplanons now, right? Oh, you still got some Implanon hanging around? Okay. If you had big supplies, you probably do, but the next time you order, you're going to get Nexplanon. So that's the metabolite again, a desogestrel. Okay. And then you've got Mirena. Dr. Hatcher talked about Mirena. Here you're getting 20 mics of progestogen only every day, levonorgestrel. You got your Paragard, which is your copper. Okay, and now see, I should edit my slides because it should say good for at least 10 years. See, Dr. Hatcher was here, he'd be fussing at me. Okay, here's Skyla. This is some new information on Skyla. It is being looked at by Forward Health. I do not know that we've gotten information that it's on the formulary yet, but they're looking at it, so maybe that'll be coming. And then we've got progestogen-only pills. Has no estrogen in them. Okay, it's got norethindrone, which is a progestin, one of the old progestins. This was one of the only progestins that was in pills when I first started, 30-some years ago. All the pills had norethindrone in them. Okay, and I put other names on there and generics, and you will see generics on the slides today. And the reason for that is it's a requirement under continuing education hours that I had to use brand and generics. So if you see them, that's why. Okay. And then you've got your combined hormonal methods now that contain estrogen and progestogen. And people were saying low dose. Right now we've got low dose combined oral contraceptives, which means we've got less than 50 micrograms of estrogen in the pills. That's the majority of the pills that we are using for family planning. And we've got 10, 20, 30, and 35 mics of estrogen out there, of ethinyl estradiol. That's what we're seeing in the pills. Unlike the 50s, the 80s, and the 100s when the pills first came out in the late 60s. Now, here's an important slide for you. You might want to flag this one. Because the combined hormonal methods of birth control, we've got 7 progestins available in the States. So when you start to doing pill management, because patients are complaining of this, that, or the other thing, and we'll look at those, we've only got one estrogen, which is ethinyl estradiol. That's the only one we've got in the States. But we have all these progestins, and then we have the metabolites. So a lot of it is we're going to have to be adjusting these unless we're adjusting just the dosage, the amount of the estrogen. So we're going to look at the generations, because if you do any reading, they'll talk about first, second, third, fourth generations. So here's your first generations of your progestins. These were the old pills. Old pills. 777. That's an old pill. Okay? 135. That's an old pill. Okay? Now, what's important about those old pills, if you look at those progestins, here's how they act. They've got low progestin activity, and they got a short half-life. Half-life means how long does it take you to get this big dose of drug in the body at its max, and then it wanes off. Okay? So we got a short half-life. It gets in there, and then it starts to wane off, and it's got low progestin activity. So when we looked at the pills, when they start decreasing in dosage, what happens is we started to see more breakthrough bleeding and spotting with those compounds, with those progestins in them, because the dosages started to decrease. So then we got some second generation, which is levonorgestrel and your norgestrel. They're more potent, and they got a longer half-life, so it takes longer to get there. But then we got some of those androgen things that people don't like. Oily skin, acne, some facial hair growth, some of those things that we kind of don't like. So then they said, well, we better try and fix that. So then we went to the third generation. Okay? Now what we did is we maintained the potency of the second generation, but we took those androgenic effects, we decreased them so they get more estrogen effect. So this is where you get your where the birth control pills were approved for acne treatment. Orthotricycline, when it came out, was approved for acne treatment as an adjunct to its birth control. This is why. We got the potency of the second generation, but we took away those androgen things that folks didn't like. And then we got the fourth generation out here, which is drospirenone, which is your analog of spirulactone. And so it has anti-androgenic properties. So we've got all this stuff out there. And we've got patients coming in with brand and generics, and we're trying to keep it all straight. So you all have got a poster today that's got pictures of pills, marvelous little gadget to have, because it's got brand and generics on it, because you need to know there's about 100 pills out there. I'm good, but I ain't that good. I can't keep them straight. I used to be able to keep them straight by color, okay? I can't do that anymore, because then they flip the colors and all that kind of stuff. So you've got to use your little cheat sheets. So the poster is good. Managing contraception is good, this little gadget here, because back in here, you have all these pictures of your pills. So for those of you who are new at this, these are tools that you're going to want to use and keep track of, because they work out really slick. Okay. And then when we look at pills, when pills first came out, we only had monophasic pills. Monophasic pills said the estrogen and the progestogen were the dosage was the same in all the pills. No variation. Number one complaint, we had monophasic pills, we had high estrogen, and everybody was complaining about weight gain and bloating. Okay, those 100 microgram pills. So then they said, well, maybe if we juggle the dosage around a little bit and try to mimic normal cycles, we'll make it better. So then biphasic came. So then that means the dosage changed twice in the pill pack. And then they thought, well, that worked pretty good, but if we change it and get 3 times it changes, we'll mimic the menstrual cycle even more, so that'll make it even better. So that's how we went from monophasic to biphasic to triphasic, and what the logic of it was. We were trying to mimic the normal hormonal fluctuations in the menstrual cycle to decrease the complaints of the side effects that patients were having. So that's where we are today. Now, on the triphasics, we have to remember though, and it's not equal in all the pills, so that the first week is this much, second week is this much, and third week is this much. That's true for some, but then other ones have 10 pills here and 6 pills there and 8 pills here, and so you just got to remember that when the color changes, the dosage changes, because it's trying to mimic menstrual cycle fluctuation of hormones. Okay, and then we've got the patch and the ring. We only have one product, releases the same amount of hormone on a daily basis, no phases. You know, what you see is what you get. There is no phases. Okay, so here we go. How do you pick a combined oral contraceptive? You got 100. You probably got, I don't know, 5, 10, 15 in your cabinet. Who's to know? If you're writing a prescription, the pharmacy's got a gazillion of them. Okay, what you want to do, you want the lowest possible dose to achieve the outcome with the least side effect. Okay, so the outcome obviously is pregnancy prevention. But we don't want the woman quitting her birth control pills because of the side effect. Because then you have unplanned pregnancy. So what are we going to do? Well, we're going to look at the history and see if they've ever used a method in the past, and if they've used a method of oral contraceptive, what was it, and what happened? I went off of it because I was bleeding all the time. I went off of it because I didn't bleed. American women are never happy. We either bleed too much or not enough. Okay? So you're going to look at your history for your clues. You have to know what happens in the body with the estrogen and progestin. Got to look at what happens in the body. And then you got to look at cost. The cost to you and the cost to her. Okay, so here's a couple of history. Patient is complaining ovarian cysts. So what do you want to do? You want to make sure that you get good suppression of the ovary. Ovarian cysts happen 2 times in a menstrual cycle without any hormones put on board. Normal menstrual cycle. You can get cysts 2 times. One right before the follicle ruptures, and the other, corpus luteum cyst, is right before the period starts. So you can get cysts 2 times in a normal menstrual cycle. But if the patient has a history of that and stuff, you want to make sure you're going to get good suppression. So you might want to consider a monophasic pill to give her good suppression because you're going to get constant dosage change. The number one method for really suppressing ovulation the best, and I'm surprised Dr. Hatcher didn't mention it this morning, or if he did, I lost it, is Nexplanon. For keeping your ovaries quiet, as I call it. You want to keep the ovaries quiet. You don't want them working, okay? You want to look at, so ovarian cysts, they got a history of it. You know, some of them will say they end up in the ER because they end up with bad pain. Some people will say, well, I've had to have surgery, da-da-da-da-da. You get some hints like that. You want to think about a monophasic pill so you keep those ovaries quiet. You see a history of anticonvulsant meds. You want to think about LARC, or you want to think about a 35 microgram estrogen pill or a potent progestogen, because your anticonvulsant meds decrease the effectiveness of your birth control pills. So you're going to get that from your history. You're going to want to think about that. We had a big chat here today about obesity. Right now, we do not have any data on combined oral contraceptives that one is better or more effective for a woman who is obese. There's some studies in the pipeline, but right now the data that's coming out is go ahead, use any formulation you want. And the fine line you have to think about walking is your obese women have a higher incidence of clotting, or clots. So you do that, you got to do that trade-off of, estrogen is clot-driven. So where do you go? And I can tell you, I've used 20 mics and they've done fine, and I've used 30 mics and they've done fine, and I've done 35 mics and they've done fine. And so it's what's in your formulary. Do they have a history of doing anything else? But right now, we don't have any recommendations about weight and combined oral contraceptives from the standpoint of effectiveness. Your bariatric surgery, you've got to be careful if there's the malabsorption issue of your medications. So the lap band is not an issue, because that's just a little band that constricts. But your Y&Y, where it takes off part of the tummy and excises part, and they do a big reanastomose on the intestine, you may have some malabsorption issues there. So you've got to be careful with your pills. LARC would be ideal, or make sure you're doing a potent progestogen if you're doing OCs on them. Okay?
There's one thing about if they have bariatric surgery, they have to wait a year before they start combined birth control?
No, they have to wait a year before they try to get pregnant. They should, one of the things they should be doing is using a method of birth control for the first year.
They talked about that too, but they talked about it having a higher clotting profile with them being bariatric.
I can tell you that there isn't anything in the data that says you wouldn't use an estrogen-progestin method. Okay, if you look at your estrogen and your progestin effects, your estrogen is going to maintain your cycle control. It's going to maintain the uterine lining. And your progestin is suppressing the ovary and thickens the cervical mucus. Okay, so think about that. Your estrogen maintains your cycle control. So one of those progestogen-only methods where you have a lot of spotting and breakthrough bleeding, it's because you have no estrogen to maintain the cycle control. But you have good effectiveness because the progestin is suppressing the ovary and changing this, and thickening up the cervical mucus so the sperm can't get through there and they can't swim well. Okay, so that would make sense when you stop and think about why we see more spotting and bleeding erratic and irregular on your progestin-only methods. So here is the number one complaint now of why people come in and say they want something changed, or they come in and are complaining about their method. The number one complaint is breakthrough bleeding. Okay? And it's very often the number one reason why they'll quit their method. because they just don't want to deal with it. So all the methods have the potential for breakthrough bleeding as a potential side effect. You're going to need to educate your patient up front. And when we get into some of the other methods, I'll bring that education back. It's very common, the first 3 cycles of combined oral contraceptives, to have spotting or bleeding. The progestin-only methods, it's common, usually decreases over time. And you want another motivator to have your women quit smoking. Breakthrough bleeding is worse in smokers, regardless of their method.
And is that age-related at all?
No. She asked, is it age-related? I'm sorry, I didn't repeat the question. She asked, was it age-related? And it's no. So your smokers have more breakthrough bleeding than your non-smokers on all their methods. Okay, now, the other thing I want you to always remember, patient comes in, complains about breakthrough bleeding, and one of the first things you want to ask them, have they used emergency contraception in this cycle? Because it will alter their bleeding patterns. And I think we sometimes immediately jump into, did you take your pills right? Did you miss any pills? Did you take them late? You know, have you had sex partner change? We jump into all this other stuff. But we talk emergency contraception a whole lot to our patient population. So also put that in your repertoire of things to ask them. Have you used emergency contraception in this cycle? Because if they have, that may explain why their cycle is off. Or if they're coming in and they change the pills and they continue to spot, and they change the pills and they continue to spot, and their committee is negative, you might want to go back and ask them, are you using emergency contraception? Because that will alter their bleeding patterns, and I think we sometimes forget about that. So that's one of those other little tips of things you want to think about. Okay. So here's some other little tips you want to look at is what cycle is the patient on? So that if they're in that first 3 months of new user, it's very common. Tincture of time is always going to help with this. But it sometimes is very frustrating for women to be experiencing bleeding and spotting. But for the majority of them, if it's in their adjustment phase, that first 3 cycles on combined oral contraceptives, it usually is going to get better. And if it doesn't by the 3rd cycle, then you need to do something. Missed pills or late pills will also aggravate it. Sex partner change may give you spotting related to chlamydia, so you want to think about that. The other thing is you want to try and differentiate. Is it really bleeding, or is it a little bit of brown discharge on the toilet paper when they wipe? Because perceptions to patients between bleeding and spotting, which is, heavy bleeding to one is, half a pad, half a tampon. Somebody else could go to 2-3 tampons in an hour and it's normal. So, but try to differentiate and see what the patient is really concerned about and how much is it, can you quantify it in any way? And then one pill is not better than the other for management for breakthrough bleeding or spotting. You got to see where the patient is. So here's some little tips. Does the bleeding continue into the new pack of pills? So they got through their cycle, they took their placebos, but then they continued to bleed. The 1st, the 2nd, the 3rd, the 4th pill in that new pack. Okay? If that happens, you want to up their estrogen. In a triphasic cycle, you might want to decrease the progestogen that's in the beginning of that cycle or change the progestin. So here, you could go from a 20 mic to a 30 mic of estrogen. That might help. Or if they're on a triphasic and they've got less progestogen in the beginning, you're going to want to change it to a higher one at the end. So tricycline, Trisprint Trinessa, has 0.18 milligrams of norgestimate in the beginning. That's how much progestogen it's got in the beginning. But at the end, it's got 0.25. So it's littler in the beginning, later at the end. You could look at a 1st generation or a 2nd or 3rd generation progestin, which are more potent. So you could do that. But remember, if you're looking at a 2nd generation, You may kick up some things that they don't like because it's got the androgen effect. Okay? Sometimes those old pills, those first generation pills, work really well because they've got norethindrone, a milligram of it, but they've got 35 mics of estrogen in it. So an old pill, 135. You know, Ortho or Nikon or Nortrel, 135. So you got to look and see where they are and what you want to go to and how you want to get there. So that would be an example for that. Okay, now, are they spotting or bleeding before they finish their pill pack? So they get, you know, halfway around the circle and they start spotting. Or they get through two rows, or the tail end of the second row and the beginning of the third, they start spotting. So they're spotting before or bleeding before. You want to up the progestin. If they're on a monophasic, change to a different one. If it's a triphasic, increase the progestin in the last part of the cycle. Okay? So if they start before they're finishing their pill pack, you're going to up your progestin. So you may have to go from first generation, which isn't so potent, to second or third generation, which is more potent. Okay, so from norethindrone to norgestimate. Okay, so you're going to have to go home and you're going to have to look at your pill packages and look at your compounds in there and say, okay, here's this. I've got this progestin, it's this generation, it does this. This is a second or this is a third, so it's more potent. You know, third got rid of all that androgen stuff on the second that they didn't like. So you're going to have, you know, and you may have to say to the patient, you know, I've got lots and lots of pills. And so we may not get it right the first time. So we'll change and we'll see how you do. And we can change it again if you want. Or if they come in with a mixed bag of complaints. I always love it when they come in with a mixed bag of complaints. You know, it's like, okay, what's the worst thing? Okay, what's bugging you the most? What do you want me, if you had to pick, what's the thing that's bugging you the most? And let's try and see if we can get rid of that. Because sometimes they've got a mixed bag of complaints. You know, or they'll come in complaining of, they're on a 20 mic of estrogen, and they come in and complain, oh my God, I got all this bloating, and my breasts are just killing me because I got all this breast tenderness. Those are estrogen when they're on a 20 mic. Where are you going to go? You know, then you may just have to change compounds. You know, people have worked with me and said, well, we got to change the compounds and see if we can make it better. Because I don't want to up my estrogen, for crying out loud. You know, that'll probably make it worse. But every now and then, it doesn't. You know, so it's not exact. Somebody used to say, medicine is not an exact science. Managing contraceptive pills is not an exact science. We've got some logic, and we've got some guidelines, but it's not exact. Okay, so then we got breakthrough bleeding, and we got breakthrough bleeding with Mirena and Nexplanon. And you see the three comments I make right in the beginning. Educate, educate, educate. Because you're going to see erratic, irregular bleeding with Mirena and Nexplanon. Here's my experience. Of the two, I saw less erratic, irregular bleeding with Mirena than I did with Nexplanon. That was my experience. Here's another little thing that was my experience, and Donna and Jackie and I were talking about this last night with Dr. Hatcher, and then he talked about it today. I made the comment, I said, I don't think there's any good research data on it, but let me tell you, if I gave them 2 or 3 cycles of pills to thin that lining out, or patch to thin the lining, or ring to thin the lining out before I did Mirena and Nexplanon, it seemed like I had less breakthrough bleeding. And Donna says, yep. Jackie says, yes. And Dr. Hatcher says, I think there is some research on that. So the consensus of the gurus the other night at supper was, for some patients, if we can get that lining thin, before we put Nexplanon in or insert a Mirena, we sometimes have less breakthrough bleeding. So I'll throw that out there as an option to you to think about. But at any rate, you have to educate, and let these people know that they're going to have some erratic, irregular bleeding. My experience more so with Nexplanon than with Mirena. And you have to find out what they're willing to tolerate. Because if they want everything by clockwork, oh, this ain't it. You know, we used to be able to say to the pill patients, you're going to know when your period is coming, probably to the hour and the day. Okay, it's regular. You'll be able to set the clock by it. You know when you put the tampon in your purse for at school or your backpack that day, the period's going to show up about 2 o'clock in the afternoon. You cannot do that with Nexplanon and Mirena. It just isn't going to happen. So you have to educate. What are they willing to tolerate? And then when they start calling about complaints is how much bleeding and spotting are they? Because sometimes they just want reassurance that this is okay, this is normal for this method, it's probably going to get better with time, and you need about 3 to 6 months, versus wanting you to do something. They just want you to say, it's okay. Is it anything we have to worry about? Okay. We don't have any good evidence-based management information. We have lots of anecdotal information, so I'll share that with you. Nonsteroidal anti-inflammatories, ibuprofen, 600 to 800 milligrams every 5 to 6 hours for 5 to 7 days. Big doses, you got to make sure they eat with it. Doxycycline, 100 milligrams twice a day for 5 to 7 days. Dr. Hatcher talked this morning about cycling with birth control pills. I've done all of this. Sometimes it works and sometimes it doesn't. Sometimes it works while they're on whatever medicine I give them, and then it's okay for a couple weeks, and then it comes back again. I don't have any magic answers. There's just no magic answers out there for that type of bleeding and spotting that occurs with these methods, and we've got to educate the patient, and sometimes they're just willing to roll with the flow and it's okay, and other times it's like, I can't deal with this anymore. Okay, breakthrough bleeding with Paragard, their initial adjustment, usually 1 to 3 cycles. They usually cycle regularly after that. Some of the data says the bleeding can be a little heavier than what they're experienced in the past. Other readings say no. I've seen both. I've seen some heavier periods with Paragard, and I've seen just common, ordinary, average periods, what they had before with Paragard with no change. Breakthrough bleeding with Depo is really common. Usually not heavy, can be. It's not a reason for concern, usually worse in the beginning. We talked last night, too, about, especially the postpartum woman, giving a combined hormonal to get that that lining thin a little bit, and then switch over to Depo. They seem to have a little, they do a better with adjustment and not so much breakthrough bleeding and heavy bleeding. Bleeding with the patch, probably going to occur the first 3 cycles, usually decreases with time. My experience has been, it seemed like the bleeding was worse the second patch of the first cycle or so, and then it got better after that. But I don't have any evidence-based, I don't have any data for that. Bleeding with the ring, common the first 3 cycles, usually decreases with time. So usually those first 3 months are their adjustment cycles, and if you can get them beyond that, the majority of it disappears. Now here's what I call bleeding distress. Didn't know what else to call it, so this is what I call it. Okay, sometimes they're so concerned about all this bleeding is because they or their partner do not want to have sex while they're bleeding. So if they've got any bleeding or spotting, 2 or 3 or 4 days more out of the cycle, they're just having great concerns. And it's like they're not doing very much bleeding, and she only notices it when she wipes, but she's just, her response to this seems like, wow. And so it's like, what's going on here? So this is one of the things, this is one of Jan's tidbits that I've learned over time. Sometimes it has nothing more to do with they don't want to have sex when they're spotting. And I say to them, that is a concern between you and your partner. There is no medical issue here. It's a social issue between you and he. You got to figure it out. Sometimes changing a method will help, sometimes not. All right, here we go. Breast tenderness, bloating, weight gain. estrogen. Estrogen, estrogen, estrogen. Get your estrogen down. They're on a 20 mic pill. Then change to a second or third generation. Yeah, Donna, jump in here.
Well, one thing that I think is important to remember when you're talking to these patients is that when we put them on birth control pills or we put them on anything hormonal, it's going to potentiate already things that already exist in terms of their behaviors. So when I have patients who are drinking a 12-pack of Mountain Dew a day,
Yeah.
and they're eating tortilla chips and high-salt diets, when you put them on anything low dose, the breast tenderness is the first thing they're going to experience. And so sometimes it's a counseling process of, and then if they're smoking even a small amount, nicotine, caffeine, and salt, and any kind of OCs, and you're going to get breast tenderness.
Yeah. Well, and let's just talk a 2 minute about weight gain. Is it perceived or is it actual? Okay. And remember, we're seeing young people that we're putting on methods of birth control. They have a maturation process that's going on. Some of them are still growing. They're developing. All these other things that go on, and yet you blame it on the method of birth control because all the birth control pills. My mother told me, that birth control pills are going to cause you to gain weight. There is no data to support that in the new generation pills. So we've got to remember, too, we're doing young people who are still growing and doing some maturation. You've got perceived weight gain. You put them on the scale, and their weight gain is the same. Their weight is the same. It's like, okay, because you remember, you start changing stuff. You may give them something they really don't like, or you may make something, you're going to make it worse, or another side effect. And so you're walking this fine line all the time. But the new data does not support, the data out there on the new low dose OCs does not support the weight gain. And that's in Contraceptive Tech, too, in the big handbook, or the big book. Okay. Nausea and vomiting are estrogen, usually in the beginning, common the first cycle. Tip, take it with food, take their pills before they go to bed. If it's going to continue, you're going to need to do something with that estrogen in there. Cramps and menstrual bleeding, because pills, patch rings, Depo is supposed to make it better, right? So if it's worse than usual, you've got to look at your estrogen, first or second generation progestin, and Mirena is approved, as Dr. Hatcher said, for heavy periods. So think about that too. Amenorrhea, here we go. We go from too much bleeding to no bleeding. You want to evaluate for correct pill taking. Clarify that there really is no bleeding because they may not realize that just a little bit of coloring on the toilet paper when they wipe is really all they're going to have for a period. I used to tell people, more than 50 cents a glip in your underwear is surplus. That's what I used to tell them. More than 50 cents, a little brown discharge in your underwear is surplus. That's surplus. So just know that what patients say to you, I'm not having any bleeding, I'm on withdrawal. Maybe they are, but they're not counting it because it's so little. But if they truly aren't, you've got to worry about, pregnancy. If you rule it out, then you've got some options. You can leave them on the same pill and know they're not going to bleed, or they're going to have a period erratically. Some people like that, some people don't. They can change it to a little more estrogen, or change to with less progestin in the early pills. So you've got some options. Sometimes if you just reassure them, it's okay, you're taking your pills correctly, you're not pregnant, they just leave it alone and go on their merry way. Hot flashes, night sweats, and dry vagina with combined orals are lack of estrogen. And some of the low-dose pills, I've had a fair amount of young women will come in and say, I'm having terrible night sweats and hot flashes and stuff. Well, maybe they need a little bit more estrogen. The lubrication for intercourse with the vagina sweating mechanism is estrogen-driven also. So that may, people come in complaining about that, or pain with sex because they're not lubricating enough. It may be related that there's not just quite enough estrogen effect for them, and you may want to do something with that. Blood pressure, slowly creeping blood pressure or a spike in blood pressure is estrogen-driven. Okay, common things. You don't make a diagnosis based on one blood pressure reading. I don't have to sing that song here. You know, how much of a rise is it over their baseline? And you're going to have to determine when you want to initiate management. Because if you remember, a MEC4 is 160 over 100. That's a MEC4. Okay? So 140 to 159 to 90 over 99 is a level 3 in the MEC. 160 over 100 is a level 4 in the MEC. Okay? Might want to get their estrogen down, second generation, progesterone-only method, LARC would be all options. But you know, you're going to have to be doing some monitoring of that pressure. They may have to be coming in a little more often. Headaches. How many like headaches? Anybody in here like managing headaches? I think they're a pain. They're difficult. They're difficult. They're estrogen related. And they say, well, I've got migraines. And the first word out of my mouth is, and you saw somebody and you had a big workup, and you've got a definitive diagnosis of migraines? Oh no, mom told me I had them. Okay. Mom had them, so I have them. Well, that may be true. Okay. But the first thing is I want to know where that term migraine came from. Okay. Who diagnosed it, what symptoms, what not else. Remember that a migraine with an aura is a level 4. Yeah, Diana?
What exactly are you constituting as an aura? I have a provider who isn't using the same definitions of aura that I.
Okay, well, let me go to my next slide and I'll give you a hint on that. Okay? The number one question I ask people is, when they say bad headache, is there anything that happens that warns you your headache is coming? And if they have an aura, they'll say, oh yeah, I get all these sparkling lights and it's just flashing like this, and I can't see out of one side, or my one arm is numb. I had one lady say to me, oh yeah, I have some trouble talking. Those are all aura. Okay? Those are all aura. And auras usually precede the headache by about a half an hour to an hour. So you have the aura, and then the headache comes. And once the headache comes, the aura goes away. Okay? So those are some clues. Does anything warn you the headache is coming? Okay? What is it? And they can tell you. Auras, they can tell you. And then say, well, how long does it last? Oh, about half an hour, but once the pain really starts, that's gone, and then I just get this really throbbing headache. Okay? So those are some hints. They can tell you there's something that warns them the headache is coming, precedes the headache by a half to an hour, and once the throb hits, the aura's gone. Diana, does that help?
Sure, that's what I go by.
That's what, well, and
One who's not using light or sound sensitivity.
well, that's a symptom of a migraine, but it's not necessarily an aura.
And if that's happening to people who've been before the headache comes, you know, that's what I think that a lot, that they're having a sensitivity to light.
Those are not true auras, though. Those are sensitivities. Well, from my management standpoint, light sensitivity is a symptom of a migraine, but it's not an aura. And what was the other one? Sound. That's a sensitivity, and it's a symptom of a migraine, but it's not an aura. Dr. King, Dr. King, go ahead.
Tell them to go to the Dr. Hatch's Contraceptive Technology course because they're wrong.
Yeah.
They're just wrong. They need to educate themselves.
Yeah. But I think if you leave here with one question today for headaches is there anything that warns you the headache is coming? And that'll help go. Menstrual migraines, nor aura and under 35, they usually come the week off pills. Do continuous cycling. That's just easy. Continuous cycling, there's a lot of people that like that. They don't have a withdrawal bleed. You can do it with any birth control pill. You can now do it with the patch that came out in the last contraceptive tech. You can do it with the ring, no big deal. There's pills packaged like that, and we do have, I used to tell people, you can bleed off once a year. Do I have any logic for it? No, other than that there's a birth control package that way. Other than that, I don't care what you do. If you want to continue a cycle, go. You know, you probably will have some erratic bleeding somewhere along the line, and that's the way it is. And what are you going to do with that if they continue a cycle? I just said all the stuff on these slides, you guys. They're going to bleed somewhere along the line, and you can manage it in several ways. You can have them go all the way through the end of that cycle, have a withdrawal bleed. You can have them stop right then and there, stay off their method for 2 or 3 days, and restart up, starting the method new again. That is more complicated for some people. Otherwise, they can just keep taking their method, and it'll quit, maybe not as soon as they like, but it'll quit. It's going to go away. Weight gain with Depo. Not everybody gains weight. A lot of people do. Some people do. Here's a little tip for you for teens especially. If the weight gain within the first shot is more than 5% of the baseline, they're probably going to continue to gain more weight as they continue to use Depo. Information's been published quite a while. Amenorrhea with Depo is going to be expected. You don't need to do anything with it unless they've got signs of pregnancy, and then obviously you're going to run a pregnancy test. Give it up on this bone mineral density, and I put this in here because I didn't know who the audience was going to be. I don't have to say any more because Dr. Hatcher already told you what you ought to do with that thought process. Late Depo, we know that it's effective till 17 weeks. We don't be telling patients that. We tell patients to return in 12 to 13 like normal. There is a wonderful algorithm in the little grape-colored book on managing late Depo. Here's a little point of discussion for you. The 3-month follow-up after the patient starts a new method may be beneficial. Some of us old folks grew up with this. This is what we always did. It's not mandated. There's things you can do at that visit that may benefit the patient. Make sure they're satisfied with their method. Are they having any problems? Side effects that haven't resolved. Assess a need for STD screening and assess need for condoms or EC supplies. And I'm done. I'm not going to do the case discussion because it's 4:30. So thank you, and thank you for all of you who stayed till the end. And if you do have questions, I'll be here for a little bit so you can come and hunchwoggle me.